Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Antonio González. He's a dear friend and colleague, and he's in the Department of Medical Oncology at the Universidad de Navarra in Madrid, and also in the GEICO group from Spain. And obviously, it is a great pleasure and honor to speak with Antonio. And of course, obviously, we're going to be talking about this very important and key article that was recently published in the Annals of Oncology, titled "Niraparib First-Line Maintenance Therapy in Patients with Newly Diagnosed Advanced Ovarian Cancer: A Final Overall Survival Results from the PRIMA ENGOT OV26 GOG 3012 trial." Antonio, it's always a pleasure speaking with you, and I want to thank you again for accepting our invitation to speak about the final results of the PRIMA trial. Thank you once again.
Oh, thank you, Pedro, for having me in this interesting podcast. This is my first time. It's a great honor. It's a great honor to share with you my thoughts about the trial, for sure.
Oh, fantastic. And I assure you certainly that this will not be the only time, as I'm sure you will be invited back again for many other important trials that I'm sure will be coming our way. So Antonio, of course, obviously, lots of questions that we want to discuss about the PRIMA. So I wanted to start by discussing what was the PRIMA trial and what were the results of the primary endpoint in progression-free survival.
So, Pedro, the PRIMA study was a randomized phase 3 study that was testing the use of niraparib as maintenance in frontline after response to platinum-based therapy. That is essentially the design of the trial, but there are some important specific patient characteristics to take into consideration. Patients included in the PRIMA study were patients with high-risk disease from the clinical perspective. That means that we did not allow the inclusion of patients with stage 3 and complete cytoreduction in the primary surgery. So almost all our patients had visible residual disease after primary debulking surgery, or they have neoadjuvant chemotherapy. Indeed, 2/3 of the patient had neoadjuvant chemotherapy. On top of that, we had a very clear platinum sensitivity criteria to be included in PRIMA study. So our patients need to have achieved a partial or a complete response to platinum-based frontline chemotherapy. So that is a very specific population. Yeah. High risk, very platinum sensitive. Patients were randomized 2-to-1 to niraparib or placebo, and niraparib was administered for up to 3 years or until disease progression. The primary endpoint of the study was progression-free survival. And we tested PFS hierarchically, first in the HRD positive tumor population. And if that was positive, then we tested the overall population. And the study was positive. The study was positive for the primary endpoint, for the HRD population, and also for the overall population. Indeed, the hazard ratio for the HRD was 0.43, and for the overall population was 0.62. One analysis that we have performed during this final analysis of the PRIMA study is the long-term progression-free survival. And importantly, this analysis has confirmed the data that we provided in the primary analysis of the primary endpoint.
Excellent. So thank you for that introduction and for going back to those results of the primary endpoint and progression-free survival. You talked a little bit about the inclusion criteria, and certainly, as you mentioned, obviously, a more higher risk of profile for recurrence than the typical patient who has an optimal cytoreduction. Any other specific inclusion criteria? And I was wondering if you could speak a little bit more about the treatment arms in terms of like what was the dosing of the medication that was given in the treatment arm.
Sure. Um, First, in terms of patient characteristics, I can provide additional data. Approximately 35% of the patient had stage 4. As I said before, 2/3 of the patients have received neoadjuvant chemotherapy, and approximately 30% of patients started the maintenance still with visible disease, so they were in the partial remission. So that is just to contextualize the high risk characteristics of our patients. In terms of treatment, initial dose of neuropathic was 300 milligrams fixed dose for all patients. But after 2/3 of the patients were included, we implemented the individualized starting dose. The individualized starting dose of neuropathic was the result of an analysis of the NOVA study, that is the study of neuropathic maintenance in second line, that showed that patients with less than 150,000 platelets in the baseline or a weight of less than 77 kilograms had a higher risk for development of hematological adverse events. So since that moment, that was, as I said, when 2/3 of the patients were already included, we implemented the individualized starting dose for patients with adequate baseline platelets and more than 77 kilograms, they started with 300 milligrams. But if one of those was not or was below the cutoff, then we started with 200 milligrams. And that was the dose of neuropathic. And actually that allows to reduce the hematological toxicity of neuropathic.
Excellent. So now let's get into the results because we have several questions about this particular paper. So tell us about what were the results of this publication on overall survival.
Well, the overall survival was a secondary endpoint in our study. We set up that the final OS will be performed with at least 60% of events. Indeed, our final overall survival analysis had a 62.5 maturity in the overall survival population, so 62% of events. That is associated with a long median follow-up of approximately 6.2 years. So one of the things that happened in PRIMA is the events came later than expected, I would say, because of the high-risk population, people expected to have OS data in PRIMA before it happened. And the final data is that there are no differences in the median overall survival or in the hazard ratio. The hazard ratio is exactly 1.01, which means that there is no difference in the OS between neuropathic and the placebo in this context. The median is around 47 months for both groups, and the rate of patients alive at 5 years is 42% and 44%. So it's quite similar.
Excellent. So, Antonio, we typically have questions from our fellows in the journal. So I will start with a question from Ali Straubhart. She's from Salt Lake City here in the United States in Utah. And she asked, I noticed that nearly 70% of patients underwent neoadjuvant chemotherapy. First, are you surprised by the high percentage of patients that underwent neoadjuvant chemotherapy? And second, How do you think this impacts the outcomes of studies, particularly considering that most patients with advanced ovarian cancer are undergoing neoadjuvant chemotherapy? Were there any differences in survival and use of niraparib based on primary surgery outcomes?
Well, first of all, I think that the rate of neoadjuvant chemotherapy in PRIMA study is higher than we usually see in the real life, in our daily clinical practice. The data is quite consistent across the different countries that neoadjuvant is roughly 50% of patients. Half of the patients receive neoadjuvant chemotherapy. So in this case, the rate of patients with neoadjuvant is higher because we did not include patients with primary debulking surgery and complete cytoreduction. So maybe that there is some bias in that rate of neoadjuvant chemotherapy. So the second point is, what is the influence of that in the outcome? And that is a very nice question, because when I always say that PRIMA population had high risk characteristics from the clinical perspective, obviously that influenced the median PFS. That is a little shorter if you compare with a study that included the lower risk population. But honestly, it doesn't impacted the overall survival in this group of patients. Actually, the median OS for this population is longer than expected, as I said before. One thing that we have learned from the PARP inhibitor trials, specifically from the SOLO-1 and the PAOLA-1, is that the patients with the highest chance to be cured are the patients with complete cytoreduction in the primary cytoreductive surgery. But in PRIMA, we still have 35% of patients in the HRD population without progression at 5 years. And the Kaplan-Meier curves remain separated, and they looks like to have reached a plateau. So I think that there is a clear impact of the PARP inhibitor also in patients with high risk, as for instance, patients receiving neoadjuvant chemotherapy.
Yeah, those are impressive numbers, 35% in 5 years. Very, very impressive. This is also an interesting question from Susana Del Frate in Italy. And she asked, in your opinion, why is there no consistent correlation between progression-free survival and overall survival? In other words, when you see a benefit in one, why doesn't that equate to a benefit in the other as well?
Yeah, that is another great question. As you can imagine, since I saw for the first time the data of PRIMA, the final overall survival of PRIMA, I have been thinking, elaborating a lot of hypotheses just to understand what happened in PRIMA. And there are two main reasons to explain why we observe a clear benefit in progression-free survival that did not translate in overall survival. One is the long survival post-progression in PRIMA, and the second is the crossover. Let me explain briefly what I mean. The survival post-progression is the time from the first progression until death of the patient. And this survival post-progression in PRIMA is longer than 40 months for the HRD population. In that period, patients receive many different interventions, including crossover to PARP inhibitor if they were in the control arm, but also surgery, bevacizumab, different chemotherapy. So there are many factors that you cannot control when you run a big randomized phase 3 study in which there are a lot of subsequent therapies. That is one reason, but the second, I would say, more strong reason is the crossover. So in our study, approximately 60% of patients with BRCA mutation receive a PARP inhibitor. I'm talking about the control arm in the subsequent therapies. Half of the patients that are HRD positive in the control arm receive subsequent PARP inhibitor, which is different in PRIMA in comparison with other studies, is that approximately 80% of the subsequent PARP inhibitor was administered in the immediate subsequent therapy, so in the second line. So probably if you mix that, this is a very chemosensitive population, although high risk, very chemosensitive, high use of PARP inhibitor in the second line. So that could have influenced the outcome of patients in the control arm. Because what I can say is that the PARP inhibitor in PRIMA was not detrimental. So the overall survival at 5 years in the experimental arm in PRIMA is exactly the same than the overall survival at 5 years in the Paola 1 study for the high-risk population, so the PRIMA-like population. The difference is that our control arm, probably for the reasons that I have said before, performed better than expected.
Yeah. So I think this is a perfect segue to the next question. It's from Spain, Elena Rodriguez. And she's asking, obviously, as she's a young gynecologic oncologist, she says, in a study design, could that be controlled, the crossover?
Yeah, that is the $1 million or euros question, how to do that. Indeed, when we brought a protocol initially, it was not allowed to receive PARP inhibitor at the progression or at the relapse or whatever happened. But at the end of the day, when the trial was running, we had the data of the studies with PARP inhibitor in second line, specifically in the BRCA population, in the HRD population. When a patient progresses, they receive PARP inhibitor. So that is the contrary wouldn't be ethical, I would say. So it's almost impossible to control the subsequent therapies in a randomized phase 3 study in which you have so long survival post-progression. You can aspire to have at least recover the post-progression therapies. That is the most you can aspire, but you cannot control for that. That is my impression.
Yeah, and particularly when there are so many choices post progression.
Absolutely.
So next question comes from Brajka Bolavekova, and she's asking, what was the criteria for randomization according to response to first-line treatment?
So the stratification factors was the best response to first-line therapy. So we stratified our patients according to partial or complete response. The other two stratification factors were the use of neoadjuvant chemotherapy, yes or no, and also the HRD status in the tumor that were stratified in deficient or proficient or unknown. So that was the way to control how the patients, the response to platinum before entering in the study.
Okay. And that, again, another great segue to our next question from Susana Del Frate in Italy. And she's asking, the fact that a considerable proportion of patients received subsequent therapy, anti-cancer therapy, may have influenced the results. Does this apply to all subgroups? So the HR proficient, HR deficient, BRCA wild type, BRCA mutants?
Yeah, absolutely. But I would add that is true, but I would add that the PRIMA study has provided very important information about the first-line therapy in ovarian cancer. So I think beyond the results of neuropathy maintenance, we have a study with more than 700 patients in which we have used PARP inhibitor monotherapy as maintenance, regardless of the biomarker, regardless of the subtype. One of the important conclusions in PRIMA is that the homologous recombination proficient, or HRD negative, is a real poor population with a clear unmet need, in which we have observed benefit in progression-free survival, which is smaller than the benefit in the HRD population. We saw that in the beginning, and probably for that group of patients, the crossover has had the less impact than the crossover in the BRCA or the HRD population. But that is a very important information, because after PRIMA and other studies in first line, we have started to conduct specific studies in first line for the HRD negative population. So it will be very difficult to see in the future studies including all comers, HRD positive and HRD negative population.
Excellent. So, Antonio, now this question comes from Mina Dages in Turkey, getting into some of the side effects. And she's asking, given the occurrence of grade 3 or more hematologic side effects, including thrombocytopenia, anemia, neutropenia, in patients receiving niraparib, do you have any pre-treatment recommendations or strategies to better manage or mitigate these adverse events? Are there specific prophylactic measures or dose modifications that could improve patient outcomes while maintaining therapeutic efficacy?
Yeah, it's a great practical question. So first of all, for starting neuropathy maintenance, you need to have some blood test that is optimal or appropriate to start the treatment. That means that you need more than 100,000 platelets at least, and hemoglobin over 9, and neutrophils over 1,500. That is the first important message. Don't start neuropathy if you have not tested the blood counts in your patient. The second message is do not start neuropathy immediately after you finish the platinum. So my recommendation is to wait at least for weeks after last platinum dose, because even if you have a good blood count, the patient is still under the effect of chemotherapy, and maybe you are adding additional safety issues. So those are very simple but important messages. The next is to use the individualized starting dose. That is critical for the patient. And the third is to test weekly the blood count of the patient and to adapt to the evolution of the blood count. The dose, maybe that you have to interrupt for a while the treatment, and depending on the severity of the decrease, you will need to restart with a dose reduction. We have tested what is the efficacy of niraparib in patients that had individualized starting dose compared to patients with fixed starting dose, and there are no significant differences. We have also tested what is the influence of the dose reduction in the efficacy, and it seems that there is no influence as well. So I think that it is safe to start with the individualized starting dose and adapt dose subsequently to the safety tolerability of the patient.
Great. Along the same lines, talking about long-term side effects, Roberto Masobrio sends this question from Italy. According to the study protocol, patients benefiting from niraparib treatment could continue it beyond 3 years. Are there any safety data available for this group of patients concerning the incidence of myelodysplastic syndrome?
Yeah, that's a great point. The number of patients that were treated beyond 3 years is limited. It's roughly 5% of the population. The incidence of the serious adverse events in terms of MDS or AML remains low, below 2.5%. It is 2.3% with niraparib, 1.6% with placebo. The difference between both arms is less than 1%, which is consistent in all the PARP inhibitor trials in frontline, SOLO 1, PAOLA 1. Taking into consideration that the follow-up in PRIMA is very long, is a median of 6.2 years. I think it's very consistent data. The incidence, because I look at when these events, hematological serious events, arrive in our study, honestly, most of them occur during the treatment. Very few occur after 3 years. So there is no a concentration of MDS and AML in patients taking a longer time the niraparib.
Yes, great information to know and discuss with our patients. This next question comes from near you, from Malaga, Jose Carlos Vilches, and he's asking, could we potentially see a better overall survival in specific groups like those patients who are HR non-determined or HR deficient BRCA wild type?
Yeah, so that is a very good question, but at the same time very exploratory. And when that is one of the risks when you have a very big study that is nice results, even if the study is not positive for overall survival, the study is providing very nice data, very important data. And the risk is to do the subgroup of the subgroup analysis. That's interesting for
all 5 patients, right?
Yeah, no, that's interesting for hypothesis generation, for just to trying to figure out what's happening in that subgroup. But the number of variables that are almost impossible to control in this subgroup of the subgroup makes every single analysis completely biased. For instance, the undetermined HRD in PRIMA, the hazard ratio was over 1. And then you say, okay, so that means that in the HR undetermined, niraparib is not only, it could be harming the patients. No, stop. The HR undetermined is a few patients. Most of them were stage 4. Almost half of the patients were stage 4. In a stage 4, you have a very wide patient's characteristics, including just pleural effusion or liver mets. So the disbalance that you can find in a small subgroup analysis is so high that you cannot draw conclusions from this subgroup analysis. The only subgroup analysis that is important are those that for which the study was stratified for. So here we can take good information about patients with neoadjuvant or non-neoadjuvant HRD positive or the other groups, but thank you for the question.
Yeah, and I think, again, your answer, I think, could be replicated exactly the same for many times when we're asked for questions about a subgroup analysis of a subgroup of a prospective study. Again, I think it's exactly the same answer. This question comes from Roberta Masobrio, and She asked, based on the results of the overall survival and the updated progression-free survival, do you think that niraparib maintenance treatment should still be recommended in the high-risk HR proficient population? Which patients in this subgroup do you think may benefit the most from niraparib maintenance therapy?
Thank you for this question, because that is the next, when you see the result of PRIMA, the next question is, well, and now what to do with these results in my clinical practice? So I will be extremely clear. I think that taking together all the information that we have, PRIMA niraparib is still a valid option as maintenance in first line for patients with advanced ovarian cancer, regardless of the molecular biomarker. That is my clear statement. It is based in the primary endpoint of PRIMA was progression-free survival, and this is a positive study for progression-free survival. The long-term progression-free survival analysis that was exploratory, but it was important just to understand what happened to the patients, confirm that the benefit is sustained along the follow-up, that at 5 years in the HRD population, there are 35% of patients still alive without progression in the niraparib arm, compared with 15% in the placebo arm. The curves remain separated, and it looks like there is a plateau. So that is, for me, enough information to use niraparib in the first line. What is the best population for PARP inhibitors in first line? Is the HRD and probably the BRCA mutated. That is, there is no doubt. There is no doubt. So the question is when to use bevacizumab, both in the HRD positive and the HRD negative. In the HRD positive, in combination with PARP inhibitors, in the HRD negative, instead of PARP inhibitor. And that is the key question nowadays in our clinical practice. What I am doing is using the platinum sensitivity to select the therapy in my patients. We have recent information from Benoit Yu with the KELIM data, the kinetic of elimination of 125, in that has been tested in both the GOG 218, the study for bevacizumab, the GOG study for bevacizumab, and also the ICON 7, and consistently has shown that patients with a poor response to platinum are those achieving the highest benefit from bevacizumab. So what I'm doing in my practice is, in the HRD positive patients with poor response to platinum, according to KELIM, I'm using bevacizumab and then adding PARP inhibitor on top of that. But if the patient has a very nice response, is very chemosensitive, PARP inhibitor monotherapy is still a valid option as maintenance for these patients. That is for HRD positive. What in HRD negative? The same. If there is a clear response to platinum, you still could add PARP inhibitor as a maintenance. If the response to platinum is not so good, then I prefer to use bevacizumab in those patients. So that is how we have integrated in our algorithm the PARP inhibitor alone, bevacizumab alone, PARP inhibitor plus bevacizumab.
Excellent. So that sets us up for the last set of questions that we have. And of course, these are more questions about asking you specifically in your practice. And this next question is about treatment at progression. So what is your treatment of choice in patients who actually progress while taking niraparib? What's your next line of treatment?
Yeah. At this moment, we are using our criteria before the use of PARP inhibitor or before the integration of PARP inhibitor. What I mean is that when a patient has a relapse that is still a candidate for platinum is still the best option for the patient. If the patient progresses on PARP inhibitor, but for any reason is not a good candidate for platinum, then I prefer single agent chemotherapy plus bevacizumab. That is clear. There is a very nice analysis recently published in Annals of Oncology that have analyzed what is the impact of the progression during PARP inhibitor in the PAOLA-1 versus the progression after completing the PARP inhibitor in terms of the efficacy of subsequent therapy. According to that analysis, there is the hypothesis that the patient that has progressed on PARP inhibitor has a lower median PFS in the subsequent therapy, in the subsequent platinum-based therapy, when you compare that with the patient that have completed PARP inhibitor in first line and then they progress and they receive platinum. That is the hypothesis, but when you analyze that paper in detail, in the multivariate analysis, the strongest factor influencing this next progression-free survival is the platinum-free interval. Patients with a platinum-free interval less than 12 months versus 12 months, the hazard ratio is 0.3, 0.3. And when you analyze the median progression-free survival, which is something like the median platinum-free interval, for patients progressing during PARP and progressing after PARP, it is 15 months compared with 30 months, 30. So I think they are completely different populations, and we are putting the focus on that they progress on PARP. Well, maybe that they progress on PARP, but they progress in less than 2 years, in less than 12 months. And if you go to the historical series of patients and you compare the response to the subsequent therapy in patients with shorter platinum-free interval and longer platinum-free interval, there are also a lot of differences. And it is not because of the PARP inhibitor. I'm not saying that PARP inhibitor is not changing the biology of some patients, and all the reversion mutations and all those histories are true. What I'm saying is that is not a red line that you say, well, the patient progress on PARP, then the patient will never respond again to platinum. That is not true. That is not true. So coming back to your question, how I treat patients that progress on PARP, as I was treating those patients before PARP inhibitor. If they are candidates to platinum, I put platinum plus bevacizumab. If they are not candidate to platinum, I put monochemotherapy plus bevacizumab.
Excellent. So, Antonio, as a last question to this podcast, which, by the way, I've really enjoyed listening to you and having this discussion. What do you tell your colleagues in gynecologic oncology when they ask, based on the results of this PRIMA manuscript, how should I modify my counseling for our patients? What is your discussion now that we have overall survival results from PRIMA?
Well, as I said before, I think that the beauty is nowadays our patients have many options for trying to cure the disease or at least prolong the progression-free survival. I think the first discussion is about surgery. It's not about the PARP inhibitors, because still surgery is the great. So it's a cornerstone for the treatment in advanced ovarian cancer, because we know that if patients had complete cytoreduction in the primary debulking surgery, that patient have a high probability of success in the long term. So that is the first discussion. The second discussion is about the molecular biomarker, the molecular subtype, the BRCA, the HRD positive or HRD negative, because that is a completely different history when you have a HRD positive or HRD negative patient. The third discussion is about how was the chemosensitivity of the patient. Maybe that you have a BRCA mutated patient and you are happy because this patient is BRCA, this patient will receive PARP, this patient will be cured, but the patient do not respond well to platinum. That's happened every day. and we have to adapt our maintenance to those patients. And then when you go to the maintenance, you have to take into consideration all the things before. Okay. And for me, not having impact in OS in PRIMA is not a limitation for the use of neuropathy, because as I said, when you compare the long-term outcome of PRIMA with similar population and the use of PARP inhibitor is quite similar. There is no detrimental effect. The experimental arm behaves as expected. I put the focus on what is for me important is what will happen in 5 years. Will you be alive and without progression? That is the patient that is cured. Median OS can be influenced by many things, but the rate of patients alive at 5 years without progression, that is the focus. And for me, it's so clear the impact of PRIMA as well as others PARP inhibitors in the HRD population that there is no discussion that we have to incorporate or keep our patients receiving neuropathy for the other options in the first line.
Excellent. Well, Antonio, thank you so much for your time. And, always, listening to you, we always learn so much. We're very, very fortunate to have had you for this long. And I'm sorry, the podcast extended beyond the promised time that I was going to take from you, but we really value your discussion and your time, your wisdom, your insight. And I really do want to thank you. I think, and I speak for the entire GYN oncology community, thank you for the contributions you have made and continue to make to gynecologic oncology.
Thank you, Pedro, but that was the work of a lot of people, GOG, ENGOT cooperation, many groups, many investigators. So I am only talking on behalf of all them and on behalf of our patients and the families that supported our patients.
Thank you.